but that also starts to anjak down. Now, very much earlier. Now, beyond about 70, I don't think we advocate for any kind of screening.
Why is it?
So, because the rates of cancer in people above 70 become very low. So, it's not that we are saying don't screen. We're saying like if you want to screen, you can screen, but not paksa lah. But the 40 to the 69 age becomes, I think, the how to say, very careful punya years. In fact, I think from people who are younger than 40, you should start by 35. Because people start getting cancer a lot more younger these days. The 35 to about 65, 68, 69 lah. What very interesting is, once you pass that 70 something, if you haven't got anything, then you get the get out of jail free card lah. So you tahan until you're 70, rajin, and then after that you all are on until you're 100 something lah.
So meaning that you have cancer, you have to do it yearly lah.
Yes.
Oh, okay.
Of course, if you're high risk, you need to continue screening lah. There's family risk and all that. And of course, if you are a survivor, look, don't forget that whatever your primary cancer is, and you're under follow-up for that, everything, you still have risk of the other cancers. And for that, you need to screen as well. So that's something that you need to be cognizant of as well. What's the last slide? Yay, okay. People can stop staring at me now. Thank you. Okay. So I'm sorry. Any more questions? As usual, I just talk too long. Yes. Okay. So now with younger women, Puan, less than about 40 something, with large dense breasts, Asians usually are large dense breasts. Ultrasound works, but the moment you're 40 and above, the ultrasound becomes less and less sensitive, which is why we are not so, recommending for ultrasound. And the other thing with ultrasound that people need to be a bit more careful is, ultrasound is very dependent on the person doing the ultrasound. Mammogram is a machine, Mammogram don't fight with the husband. Mammogram never have diarrhea in the morning. Mammogram not going to get emotionally upset because the daughter didn't pass exam. So with the machine, the accuracy is a lot higher. With ultrasounds, the problem is there's always this operator dependency. And sometimes, I fought with my wife today. So I'm not saying it happens, but there's possibility of it happening. Human judgment. So ultrasounds, again, that's why they're not so much the first modality, but in younger women, they are much more accurate. That's why. Sorry, somebody else had a question? Yes, sir.
Is 5-year survival rate still the benchmark for successful cancer treatment?
Sorry?
The 5-year survival rate. Is it still the benchmark?
Absolutely, simply because that's the only, easy objective marker that we have. In the sense that how many people, because actually there's also a 1-year survival rate. And there's a 5-year survival rate. So for some cancers, for example, lung cancer, I don't know whether there's anybody associated with lung cancer in this room. Lung cancer, we used to actually use a 1-year survival rate because survival is very poor for lung cancer. But the lung cancer landscape in the past maybe about 8 to 10 years really transformed. So really people now with lung cancer are living 7, 8 years, 9 years, 10 years. So it's actually the 1-year survival rate, 5-year survival rate, and the 10-year survival rate. So all three are used. The mean, most cancers fall within this. You can see change, the bigger numbers between the 5-year survival rate. That's why we use the terms. Doc, how are you?
Tax-based strategies, would they enhance screening rates or not otherwise? Meaning that, say, if those who go for screening, they can claim relief for the amount of money you spend on that. That's one. The other thing is for those in the rural areas, a more nuanced kind of approach involving the religious leaders or the Ketua Kampung. Maybe that would enhance participation rate in San Francisco. Thank you.
Absolutely. So, Doc's asking whether if I give you tax incentive, would you screen better? As Doc himself would be probably well aware, we have this incentive in for personal income tax for more than 10 years. However, it is not very successful simply because less than 10% of the population actually paying tax on an individual income level. So that's a challenge. And our tax bracket actually gets smaller now. There's actually a lot less people paying income tax because a lot of people now going for informal job, gig work, non-formal work. So actually the tax base getting smaller and smaller. So the impact of that incentive not so visible anymore. But however, just to share with you all, I think you can claim up to 1,000 ringgit to do screening every year. So, and for those of you all who have working children, pow them. No, because they can get that tax relief onto them. Just to share in case you all didn't know. Okay, so that's that. Sir.
Professor, just now you
Yes, sir.
mentioned that
Good morning.
Professor, just now you mentioned those who are above 70, the risk of incurring cancer is much less.
Absolutely, sir.
So in other words, those who are 70, 80, 90, they do not have any cancer. So in other words, that they are, the risk of dying which be due to other diseases. not
Absolutely,
cancer.
absolutely. So the risk decreases by about close to 80%, sir, after about 70 something. So that's why it becomes like, even if you did, because there are people who develop very late cancers at about 90 something, but rarely it is the cancer that kills them, exactly as what you say, because there's the other system will shut down. So respiratory or cardiovascular, those parts we still can't replace as yet.
So okay, just after 70, you just stop the screening.
Yeah, that's why we say we don't push for a formal screening, but you're always welcome to continue going on for screening. That's fine. We still will never say no. If you want to screen, we'll still allow you to screen. It's not an issue. Absolutely. So, if I don't have any more questions, thank you so much. I'm going to turn it over to my next set of colleagues. Dr. Tamad is coming.